Hi, this is Brian Kim. I want to share with you episode 230 in the best way to do cataract surgery series. And again, please keep in mind, I'm not saying this is the best way to do cataract surgery. What I'm trying to get you to think about is your best way to do cataract surgery, which means thinking critically of your technique and constantly trying to hone and refine your technique so that you can provide the very best for your patient. And so this is a routine cataract surgery in a moderately dense lens. You're going to see me employing mechanical fracturing, double chop, and cross chop technique to reduce CDE and efficiently disassemble this lens. Using a cotton tip to steady the eye, this is a corneal marker which will help me to center and size the rhexis. You can see that this is probably a left eye because the eye is trying to turn towards the right of the screen. Holding the eye with a cotton tip, go ahead and make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. Turning the eye downward using the Orlac technique, and this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then using the cannula to turn the eye towards me, and then I'm able to enter. This controls the length of the incision. You can see this patient has quite a bit of a Bell's reflex. And these are the Haldane-Perkar sharp tip forceps. I puncture the center, and you can see as I puncture the center, I'm going to pull down towards me, and then grabbing the right side of the tear when I'm ready to turn, and where I turn will dictate the diameter and size of the rhexis. So pulling down towards me, pushing a little bit to the right, grabbing the right side of the tear, and then going around circumferentially, trying to make sure that the rhexis aligns with the corneal mark that I made, which will help me to achieve a well-centered and sized rhexis. You can see these low-profile forceps are really great. They reduce OVD egress. I don't have to continue to pull centrally with this forceps, and it goes through a very small incision as well. Burp some viscoelastic out. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge. You can see that the cannula is pointed towards the left. It's nice and flat. I'm able to slide it under the rhexis edge. And when I get to the Capsulorhexis, you can feel a little bit of a nudge of the capsule. You're going to turn the tip down. And because the tip is so embedded into the lens material, as you gently push the fluid for the BSS, it propagates very easily and naturally to separate the posterior capsule from the lens. It doesn't tend to reflux anteriorly, which is more typical if you use a traditional technique. And it's because you're placing that cannula tip deep within the Capsulorhexis. Again, I'm not pushing it against the capsular bag. I'm pushing a little bit towards the center to make sure I create a little bit of space, and then I push. So here we go. We slide under the rhexis edge, create a little space, and push, get a beautiful wave, lifting the lens up to decompress the bag, sweeping under the rhexis edge with the cannula and pushing some BSS as I do it. And as you can see, the lens begins to spin. Really a beautiful technique in my experience, and very consistently able to achieve successful hydrodissection. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. By removing the surface epinuclear material, I'm able to have a little bit of a step off, and then I'm going to pronate my hand for the chopper, making sure I'm leading with the tip, and I'm under where I removed that epinuclear material, sliding under the rhexis edge contra-incisionally, pointing the tip down, turning the figurative vertically sub-incisionally, but you can see it's already embedded into the lens. I did not initiate any ultrasonic energy. I have not done anything. This is purely with irrigation only. I'm able to stab into the lens sub-incisional. Why? Because that's soft lens material. I'm able to then, because I'm fairly deep with the chopper and the figurative, I'm able to flank the endonucleus, which is in the center. Remember, the endonucleus is denser, but the epinucleus is not. And so I have the instruments flanking the endonucleus. Again, I'm able to embed into the lens material and flank it because that outer material is softer. It's through the epinucleus. Again, I'm able to position the instruments in such a way that it's flanking the lens. Again, I'm not using any ultrasonic energy or vacuum. This is very safe. I'm not going to accidentally hurt anything as I do this. I bring the instruments together and it fractures the lens completely in half. You can see I'm having the chopper tip slightly sideways, and this goes to show I don't have to point it down, and especially in this case because it's a softer lens, I was able to turn that chopper in such a way that the tip was not facing down but actually was holding sideways. I slide the chopper under the right heminucleus, hooking the peripheral lens, and because the phaco tip is already in that central groove, I'm able to position both the instruments deep so that it's flanking that right heminucleus, and I'm able to cut that right heminucleus endonuclear material by hooking the peripheral lens with the chopper, pulling it centrally toward the phaco tip, which again is within that central groove, pulling it centrally, and I'm fracturing that right heminucleus against the phaco tip. Using some vacuum to grab that first quadrant, and then placing the chopper around the lens and crushing it with the instruments, and then again crushing the lens with opposing forces, and then emulsifying the lens pieces. Grabbing that fragment up with a little bit of vacuum, positioning the chopper around the lens, crushing it between the instruments, and then emulsifying the lens piece. Very efficient way to remove these lens pieces in this moderately dense lens. Sliding the chopper under that second quadrant, hooking the peripheral lens, loosening it up, and then grabbing it with some vacuum, crushing the lens into smaller pieces, and then emulsifying the lens piece. Turning the second heminucleus in front of me very gently without causing any zonular stress, placing the chopper under that heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, and fracturing the lens against the phaco tip, using some vacuum to grab that third quadrant, lifting it up, and then crushing the lens with the instruments into smaller and smaller pieces, and then emulsifying the lens piece. Very controlled, systematic, and easy way to disassemble this endonucleus into smaller pieces using mechanical fracturing forces. Grabbing that last quadrant up, lifting it, and then getting the chopper around it, crushing the lens with mechanical fracturing forces, crushing it into smaller and smaller pieces, and then emulsifying the lens piece. So now the entire endonucleus has been completely removed, again, primarily using mechanical fracturing techniques, namely double chop and cross chop. Grabbing the edge of the epinucleus and begin to stumble out of the eye with vacuum. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the I&E handpiece. I always start subincisionally, peeling the cortex from anterior to posterior. By doing it this way, you get a clean removal of the cortex and less likely to have the very annoying, wispy cortical material, cortical remnants in the bag. Switching to polish mode, polishing under the rhexis edge, removing any lens epithelial cells that are there, as well as any potential fine cortical wisps. Polishing the posterior capsule as well. Again, using the polymer tip, very easy and very controlled. And I never worry about rupturing the bag with this polymer tip. It just gives you a lot of peace of mind, and you can be more aggressive in removing lens epithelial cells. Pulsing BSS into the subincisional capsule fornix, which was clean in this case. Pushing some cohesive viscoelastic, but before I do that, disengaging the irrigation to turn it off, and then using the sweep to sweep and polish under the rhexis edge on the left side first. and then the right side here. By using the sweeper through either incision, this gives you maximal cleaning ability to remove the lens epithelial cells in the subincisional area. Placing the single piece acrylic lens into the capsular bag, you can see such a beautiful big pupil in this case. Going in with irrigation off, activating irrigation, disengaging the haptics off the optic, tilting the lens, getting underneath the lens, removing all the viscoelastic from within the bag, making sure I remove the cortical material that might be between the lens and the bag as well, repositing the optic back down, polishing under the rhexis edge as well, and then I'll remove the viscoelastic and then I'll hydrate my incision. So again, this is a routine, moderately dense cataract. I was able to employ double chop, cross chop, mechanical fracturing concepts. Before doing so, I used the Haldey-Perkar forceps, which are the low profile rhexis forceps, to be able to get very good controlled rhexis. And again, using the corneal mark that I made to get perfectly well-centered incised rhexis, performing hydrodissection using Capsulorhexis hydrodissection technique, triplanar corneal incision using the 2.4 millimeter diamond blade that I have. Again, using double chop, cross chop, mechanical fracturing concepts to crush the lens, flanking the lens with the instruments. Again, because the epinucleus is soft, I'm able to very easily just position the instruments around the lens and then crushing it. Not having to sculpt, not having to lollipop the lens using vacuum, not using any phaco energy to go and trying to grab it and using purchase. Again, that is kind of the old traditional way of teaching cataract surgery using a chop technique. I don't ever go and never use ultrasonic energy. Why? Because I don't have to hold the lens. All I need to do is position the instruments around the lens, flanking it, and by bringing the instruments together, it just crushes it. So again, it's not that complicated, but it sounds like a weird way to do the surgery. But because I do it this way, I'm able to really expand my ability to fracture the lens in various angles. And even in cases where there's weak zonules or in cases where I cannot get the lens out of the bag, I'm able to, again, with a lot of confidence and versatility, disassemble the lens. And again, this is a case of just a routine, moderately dense cataract performing double chop and cross chop and mechanical fracturing techniques. So I hope this was helpful to you, and I thank you for your attention.